today in honor of Leukemia and Lymphoma Awareness Month. So we hope that we give you some helpful information and again answer any questions that you have at the end of the webinar. So today, as you know, we're going to be talking about leukemias and lymphomas and whether or not they are inherited. Before we get to that, though, I think it's important that we have just a brief overview of blood cells, how blood cells can develop into cancer so that, again, we have an understanding of these types of cancers and how they can be inherited and passed down through a family. So just very basic review. Within our bone marrow, which is inside of our bone tissues, we have what are called stem cells or a blood stem cell. So that's an immature cell that can then go on to differentiate or develop into the specific types of blood cells that we have in our body. In general, these stem cells can develop into red blood cells, which carry oxygen throughout the body, white blood cells, or leukocytes, which help fight infections, and platelets, which are important in controlling bleeding. So now we're going to make it a little more complicated just to show you all the steps along the way that go from a stem cell developing into specific types of blood cells. So the first thing that happens is these stem cells get broken down into either a myeloid progenitor cell or a lymphoid progenitor cell. So that means that that's the first step in differentiation or in the specifics of a stem cell becoming different types of blood cells. Once that happens, then you can see the myeloid cells and the lymphoid cells further break down into specific types of blood cells. The important thing to note from all of this is, as you can see, there are a lot of steps along the way, a lot of things that need to happen for these blood cells to develop properly. Most of the time that does happen, but because there are so many intricate steps along the way, there are multiple places where mistakes could happen, which could then lead to the development of a blood cancer. I also wanted to do a very quick review of the lymph system. We will be talking about lymphoma today. So I wanted to give you a sense of what the lymphatic system is. So this is a very important system in our body involved in fighting infection. The lymph system has many different elements to it. First, lymph nodes or lymph vessels. We also know that the lymph system includes the tonsils, the thymus, the spleen. So all of these parts of the lymph system are very important in our body's immune defense or in our body's ability to fight infection. Okay, so we had talked a little bit already about blood cells. So now in the development of blood cells. So now I just want to talk more about types of cancers that can develop in blood cells. It can get a little more complicated than this, but in general, there are three types of blood cancers that we think about. First is multiple myeloma. So multiple myeloma happens when there's an overproduction of abnormal plasma cells. Plasma cells are a specific type of white blood cell. Multiple myeloma is one of the less common blood cancers. We see about 35,000 new cases of multiple myeloma in the US every year. It tends to develop at older ages, so the average age of diagnosis is 69. Excuse me. Um, Leukemia happens when there's an abnormal production of white blood cells in the blood. Leukemia can be further broken down. Again, in general, there are four main types of leukemia, and they can be broken down based on a couple different characteristics. The first characteristic that we use to classify leukemia is the type of cell that becomes cancerous. So as you can see, I have four types in parentheses: ALL, AML, CLL, and CML. The second letter tells us which type of cell is affected. So the L is for the lymphoid cells and the M is for the myeloid cells. So if we go back to that diagram that we had, you remember the first step in cells, stem cells becoming specific types of blood cells was them differentiating between lymphoid and myeloid. So a lymphoid leukemia affects the lymphoid cells, a myeloid leukemia affects the myeloid cells. The other thing you notice is the first letter is either an A or a C. That's referring to acute or chronic. Acute leukemias primarily affect the more immature blood cells. These tend to progress rapidly, where people have a sudden onset of symptoms and the symptoms progress very quickly. With chronic leukemias, we tend to see the more mature blood cells affected, and the symptoms can develop more gradually and might not be noticeable for a long time, sometimes even years. So, in general, those are the main ways that leukemias are classified. Just some facts about leukemias: ALLs are more common in children. For AML, we tend to see that in later adulthood. Average age is about 69. CLL and CML, again, we tend to see later in adulthood. CLL average age of diagnosis is 70, and CML average age of diagnosis is 64. Now, moving on to lymphomas. So, we had talked about the lymph system. So, lymphoma is abnormal production of white blood cells anywhere within the lymph system. There are two main types of lymphoma, and again, these can get broken down further based on subtypes, but the two main types are Hodgkin lymphoma and non-Hodgkin lymphoma. Lymphoma is the most common of the cancers that we're going to be talking about today. We see about 90,000 new cases diagnosed in the US every year. Hodgkin lymphoma is most commonly seen in people in their 20s. Then that risk kind of falls off until it increases again after the age of 55. Non-Hodgkin lymphoma can really occur at any age, but we know that more than half of it occurs over the age of 65. The reason that I'm focusing so much here on the age of diagnosis is because we'll talk more about that later when we talk about features of inherited cancers. It's important to keep in mind the expected ages for these types of cancers to develop. So now that we have a background on what the different types of blood cancers are, I wanted to spend some time talking about the symptoms of blood cancers. Before I get there, though, I always like to point out that any one of these symptoms can be seen as part of less serious conditions. It's really more of a concern when we're seeing these for a prolonged period of time, persistent, not going away. If we're seeing a combination of many of these different symptoms, anytime you have anything, symptoms like these that you're concerned about, we do recommend that you speak with a physician. Okay, so symptoms of blood cancers. First is a cough. Again, if you have a cold or COVID or some other infection, it's not unusual to have a cough. But if you have a prolonged cough with no real reason for it, definitely something to get looked into. Unexplained bruising. So that doesn't mean, you run into your nightstand and get a bruise on your calf. Unexplained bruising is when you wake up with bruises on your body and, you have no idea where they came from. Or if you have, just a gentle touch and you develop a bruise, you bruise very easily. That's important to think about. Pain in bones, joints, or abdomen, frequent infection. So that means if you keep getting sick, if your infections are hard to treat, something again to look into. Tiredness. I always joke I'm a mom of three kids with a full-time job, so I'm always tired. But cancer-related fatigue is different. So cancer-related fatigue means that you really are having problems functioning or carrying on your day-to-day activities because of your level of fatigue. So that's different from our sort of everyday tiredness just from our lifestyle. Unexplained fever, again, just like we talked about with the cough, unexplained fever means you're getting fevers with no known cause. So you're not sick, you don't have COVID, you don't have pneumonia, you don't have strep throat, you're just getting fevers for unknown reasons. And again, if we're seeing this persistently, that's something to look into. An unexplained rash. So you develop a rash without changing your laundry detergent or doing coming into contact with poison ivy. If you just suddenly develop a rash for no reason, worth looking into. Unexplained weight loss. So that means that you're losing weight without trying. That can be a cause for concern for many different cancers. So anytime you're losing weight fairly rapidly without trying, it's good to check in with a physician. Shortness of breath, paleness, so paleness that's unusual for your skin tone, drenching night sweats, so waking up in the middle of the night covered in sweat, again, if this is happening for a prolonged period of time. Then, of course, if you have any lumps, bumps, or swelling anywhere in your body, important to check in with your physician. As far as how blood cancers are diagnosed, there are several different tests that can be used, and the way that the testing is done really just depends on what the physician suspects, what your symptoms are. I do want to point out, though, that unlike mammograms that we use for screening for breast cancer or colonoscopy for colon cancer, we generally do not screen for blood cancers for healthy people in the general population. So usually, testing for blood cancers is done if you're having any of the symptoms that we talked about, or if we know that there's one of these inherited syndromes in your family, which we'll talk more about. But in general, for somebody who's experiencing symptoms, at the very least, blood testing will be ordered. Sometimes imaging testing, such as a CT scan, a PET scan, X-ray, could be ordered. Sometimes physicians have to perform a bone marrow biopsy or aspiration, which is where they take a sample from the inside of your bone tissue to look at those developing blood cells. In the case of lymphoma, sometimes they need to remove some tissue from a lymph node to see if there's cancer in there. And of course, is always a thorough physical exam. Okay. So at this point, we've talked a lot about the signs and symptoms of blood cancers, the different types of blood cancers. So now we can talk more about what factors increase our risk for blood cancers. Uh, it's important to remember when we talk about these risk factors that in general, there's not one singular risk factor that causes blood cancers to develop. For most people, if they do develop a blood cancer, it's due to a combination of different factors. So, if you have one or two of these risk factors, that doesn't mean you'll develop a blood cancer. These are just factors that could increase risk. First is smoking. I think most people think of lung cancer as um, being the uh, um, type of cancer that is mainly affected by smoking, but we do know that it can increase the risk for blood cancers as well. Radiation exposure. Very important that you understand that this does not mean X-rays or CT scans or MRIs diagnosis type of radiation. What we mean by radiation exposure is exposure to something like an atomic bomb, working in an atomic weapon plant, or being by a nuclear reactor accident. That's the type of radiation that can increase risk. Having a history of a previous cancer that was treated with chemotherapy can increase the risk for blood cancer. So certain chemotherapy treatments can impact your blood cells and increase the risk for blood cancers. Excuse me, age. So as you might remember, when we were talking about the different types of blood cancers, I did mention that there are different ages at which we expect these cancers to develop, with the exception of ALL and Hodgkin disease. Most of these cancers have a higher chance of developing the older you get. Race. We do know that certain ethnic backgrounds have a higher chance of developing cancers. The most salient example of this is multiple myeloma. We can see almost a two-time higher risk in people of Black ancestry to develop multiple myeloma compared to other ethnic backgrounds. Infections. So we're not talking about colds or the flu, infections like that. There are specific viruses that we know can increase the risk for lymphomas. Um, Many of you may or may not have had mono as a teenager, and that's caused by the Epstein-Barr virus, which we know can increase the risk for lymphoma, as well as the HIV virus associated with AIDS. AIDS infection can increase the risk for lymphomas and certain types of leukemias. Gender, there are certain types of blood cancers that are more common in males than females. Chemical exposures. We know that there are certain chemicals that if you're exposed to on a long-term basis can increase risk, such as benzene, which can be a common workplace exposure. Um, there's also concern of exposure from Agent Orange, which was used in the Vietnam War, possibly increasing the risks for certain types of blood cancers. And last but not least, which we're going to be focusing on for the rest of today's talk, are genetic conditions. It's important to note, I'll just note this right here, that the majority of blood cancers develop sporadically or by chance due to a combination of many of these different factors that we've discussed. We will talk today about some families that have hereditary blood cancers, meaning that there's a high risk for cancer running through the family. We do know, however, that even if there isn't one of these conditions in the family, having a close relative or first-degree relative, such as parent or sibling, can increase the chance of developing these cancers. So again, today we're going to be talking more about the families where we see this high risk running through the family, but we do know just having a close relative with one of these blood cancers can slightly increase the risk for the development of that type of cancer. Okay. Any of you who have been on our webinars before might recognize this slide. This is a very important discussion to have before we talk more about inherited cancer, and that is, what is a gene? The reason that this is important is because inherited cancer is caused by problems in a gene that are being passed down through the family. So a gene is a piece of DNA that gives the body information on how to do a specific job. They are passed down to parents, from parents to children. In general, everybody has two copies of every single gene. One gene copy comes from their mother, one gene copy comes from their father. A mutation is a mistake in a gene that makes the body unable to do that job that it's supposed to be doing. Just like genes are passed down from a parent to a child, if a parent has a mutation in a gene, that mutation can be passed down to a child. When we're talking about inherited blood cancers, what happens is there are certain genes that are involved in stopping these cancers from developing. If there's a mutation in those genes that are passed down through the family, that means the body is not as able to stop these cancers from developing, and there can be a higher risk for the development of these types of cancers. There are some key facts about these types of blood cancers that are passed down through the family that I wanted to talk about before we talk more about the features in families and how the genetic testing works. So, different gene mutations can be passed down in different inheritance patterns in a family. Excuse me, we can see dominant inheritance, which means that just a mutation in just one gene copy is needed to increase cancer risk. So again, we get two copies of every gene, and in dominant inheritance, just one of those copies needs to have a mutation for higher cancer risk. Recessive inheritance means that we need a mutation in both copies of those genes in order to increase cancer risk. So that means a person inherits a mutated gene from mom and from dad to cause increased cancer risk. Lastly, we can also see X-linked inheritance, which means it's passed through the X chromosome. In general, when we see X-linked inheritance, that's something that typically shows up more in the males than the females in the family. Inherited gene mutations can increase the risk for only myeloid malignancies, only lymphoid malignancies, or for both types. So, depending on what gene is involved, there can be a specific type of pattern of cancers that we would expect to see in the family. This is a really important point that I want you all to remember. Some gene mutations can cause isolated cancer risk. So that means inheriting one of these mutations can increase blood cancer risk, but does not increase the chances of any other health problems. The classic example of that is the DDX41 mutation, which accounts for a significant proportion of myelodysplastic syndrome and AML in adults. Um, so having a mutation in this gene does increase the risk for those types of problems, but we don't see any other health problems with that. Blood cancer gene mutations can also be associated with a syndrome. A syndrome means there are other health problems or physical features that can be seen. So we do see the increased cancer risk, but we see that in conjunction with other problems, such as bone marrow failure. That means basically the bone marrow is not able to produce any significant amount of healthy, mature blood cells. Many of these syndromes are associated with ALL, or I'm sorry, many of the syndromes associated with ALL or lymphoma can also cause other features such as immunodeficiencies, which means a body's inability to fight infection properly. Sometimes we see other blood count abnormalities or some distinct physical features that indicate that a person has a particular syndrome. Okay. Uh, so at this point, you might be wondering, well, how do I know if this is something I should be concerned about in my family? Maybe you do have a family or a personal history of one of these cancers, and you want to know what should I be looking for um, to let me know if I should be considering genetic testing. So, in general, there are certain features that we can see that would raise concern of one of these problems in the family. First would be if one individual in the family has had a history of multiple cancers, including a blood cancer. So even if somebody has had multiple solid tumors and then develops a blood cancer, that could be a red flag. A solid tumor is referring to the types of cancers like breast cancer, colon cancer, the types that develop tumors. If we see a family history of early onset cancer or multiple cancers in close relatives, so not necessarily just blood cancer. So if there's somebody in the family who has a blood cancer, but they also have multiple family members who have had other types of cancers, that's something to think about. We had talked about the ages of diagnosis for particular cancer types. So if we see cancer, a specific type of cancer developing at an unusual age for that cancer, that can be concerning. So a good example of that is ALL is much more common in childhood. AML is much more common in adulthood. So if we see AML developing at an earlier time, that could be a clue. If we see the acute leukemias in multiple family members, so remember the acute leukemias are the ones that tend to come on pretty quickly and progress rapidly. If we see an individual with lymphoma who also has a history of recurrent infections, again, one after another, or infections that were very difficult to treat or required hospitalization, that could be a sign of immunodeficiency. So that in combination with lymphoma could be concerning for an inherited form of cancer in the family. Also, if we see a family member who had treatment for either blood cancer or a different type of cancer and it experienced significant complications resulting in reducing or having to stop the therapy, that could be a concern. As we all know, side effects from chemotherapy can happen. Sometimes people do have to take a pause in treatment, but if we're seeing pretty excessive complications that had to result in stopping therapy, that could be a clue that one of these inherited syndromes is causing that. We can also get clues from somatic testing. So, somatic testing is genetic testing of just the cancer cells, excuse me, to help make treatment decisions. Sometimes, though, when we do the testing of the cancer cells, we can get clues that there might be a hereditary cancer involved. So, specific gene mutations, for example, if we see multiple mutations in the same gene, um, can give us a sense that perhaps there is one of these inherited conditions. So even though we're using the somatic testing to help make treatment decisions, it can give us clues as to what might be going on in the family. It's also important to consider genetic testing, again, if any of these features are present and a blood relative is being considered as a donor for a stem cell transplant. And that's very important because if there is an inherited condition in the family, we don't want to use a donor that also has that inherited condition. Um, Obviously, the transplant won't be as successful. Also, I had mentioned before, some of the syndromes have physical findings. Sometimes we can see what are called cafe au lait spots, which are hyperpigmented spots on the skin. We can see early graying, so that's graying before the age of 25, and the white population before age 30, and the black population. We see easy bruising, abnormal bleeding, or any birth defects, such as additional fingers or toes or developmental delays known in the family. And again, that's in combination with family members with a blood cancer. As far as how genetic testing for inherited blood cancers is performed, we'll be talking on the next couple slides about how we do this testing. There are some differences from how the genetic testing is done for other types of cancers, so we'll talk more about that. Just like any other type of cancer that we've talked about in the past, it really is ideal to start the genetic testing in a family member excuse me, who's actually been diagnosed with the blood cancer or who might have any of the signs and symptoms that we've talked about. With blood cancer, too, it's important that the testing is done as close to diagnosis as possible. Generally, the testing is done through panel testing, which means we're looking at multiple genes at one time. So we're not just looking at one gene to determine if there's an inherited risk in the family. Excuse me, we're looking at multiple genes that we know can be involved in inherited risk. The panel used might vary based on the lab that's doing the testing, insurance coverage, as well as the suspected syndrome. What's very important to remember for blood cancers that's different compared to other types of cancers when we're testing for an inherited risk is the type of sample that is used. Excuse me, I'm so sorry. So, in contrast with solid tumors, where we can get a very reliable source of DNA from the blood or saliva or a cheek swab, that's not necessarily the case with blood cancers. So, in blood cancers, when we're looking at blood cells, we're actually looking at tumor cells. Again, in a blood cancer, the actual cancer is the blood. So when we look at the DNA of the blood, we're not looking at the genes that are inherited or passed down through the family. We're actually looking at the genes of the tumor. So looking at the blood is not an accurate way for us to determine whether or not somebody has inherited a gene mutation because that's not the DNA that we're sampling. Um, and what's interesting is some people say, well, then why can't we give a saliva sample or do a cheek swab? And the reason for that is because even saliva samples and cheek swabs actually contain a significant amount of blood cells. So again, we would be sampling tumor tissue and not blood tissue. It's also important to remember that somebody who's had a bone marrow transplant for treatment will actually have the donor's genes in their blood. So if we did a blood sample or a saliva sample or a cheek swab on somebody who's had a bone marrow transplant, all we'll be getting is the DNA of the person who donated the bone marrow and not the DNA of the person who's been diagnosed with the cancer. So for these reasons, really the ideal way to get a sample to get the most accurate results is to use skin cells, which can be very easily obtained through an outpatient procedure called a skin punch biopsy, where they take some skin cells, send it to the laboratory, and the laboratory then is able to get an accurate look at the DNA that's passed down through the family. So at this point, it's important to think about, well, just because we can do this, should we be doing this? Why would my family want to be evaluated? What type of information can we get from this that could be helpful for us? So there are several different reasons why it's helpful to know if there is an inherited blood cancer in the family. First is very important. It can change the treatment or follow-up recommendations for a current blood cancer diagnosis. So many of these inherited blood cancers have very specific published guidelines on what type of treatment should be used that might differ from what should be used for somebody with that type of blood cancer who does not have an inherited condition. If you remember, I had mentioned when we were talking about features of inherited cancer in the family that sometimes we can see excess toxicity or side effects from treatment. So that's something to keep in mind if somebody does have one of those conditions that causes problems like that. Their treatment might be different and very important for their physician to know. Um, we talked about this earlier, but really important when considering a family member for transplant. We want to avoid using a family member who has the same inherited mutation um, as a donor. It gives information about how the gene mutation is being passed down through the family. So you might recall that we talked about that these mutations can be passed down in dominant, recessive, or X-linked inheritance. So finding out what the gene mutation is gives us an idea of who else in the family could be potentially at risk for carrying the same gene mutation. And then once we identify those family members, we can also do genetic testing for them to give them information about their own risk. If they have inherited one of these gene mutations, then they could consider different screening or surveillance guidelines in conjunction with a physician. You remember I had said generally screening for blood cancers is not something that's done like we do screening mammograms or screening colonoscopy. Um, so this would be important for somebody to know that they're at high risk to work with their doctor to develop a screening plan for them. Lastly, it might change the treatment plan for a family member with a solid tumor. I keep saying this, but just to remember, solid tumors are those that are not blood cancers, so breast cancers, colon cancers. Um, the treatment options again might change based on knowing that there's one of these mutations in the family. And before I pass it over to Kelly Nickelbein to talk more about the impact program, I just wanted to show some Thermo Fisher scientific pride and just mention to you that Thermo Fisher is behind the scenes in developing products that really make a difference in the treatment of some of these types of blood cancers. So Thermo Fisher is a very important producer of products that go into CAR T cell therapy, which is a more recent therapy that has developed for the treatment of certain types of blood cancers. You can learn more about Thermo Fisher's efforts to develop these products on the Cancer Research website, and Jillian is going to be putting the information also in the chat so you know where to go for that. So I am going to turn it over to Kelly, who's going to talk more about the impact program.
Great. Thank you so much, Julie. This is an incredibly complex topic, as you all are probably getting the idea from. We covered it in a very high level overview. I think the benefit of having us here, as the impact program is that if you have very specific situations and questions that we aren't able to get to today on the call, you can please consider enrolling and we can have one-on-one conversations about the specifics for yourself and your family and provide even more detailed information. I would like to say, Julie Goldstein, Jillian Sotelo, and I are the members and the team for the Impact Program. We are genetic counselors. And so our expertise is really within the clinical cancer genetics space. And so there may be some questions that we're not necessarily able to answer that are more medical in nature that we may just kick over to a physician. But in terms of the genetics, we're happy to talk about that and provide additional resources and information. When someone decides they would like to enroll in the impact program, what you should know is that there are a variety of services that we can provide. So initially, you are provided an impact navigator. So that would be one of the three of us. And we are a single point of contact to provide that, general guidance, answer questions. We can also help to coordinate other benefits that are provided by Thermo Fisher. So anything that might be applicable or benefit someone that has a cancer diagnosis or is concerned about it, such as the virtual medical second opinions, in addition to a variety of others. We can provide genetic counseling in most of the states. We can also provide some facilitation of genetic testing. As Julie mentioned, with blood cancers, it can be a bit more difficult, especially with the need sometimes for the skin biopsies. I will say, because of the complexity of blood cancers, if we really are concerned about an inherited blood cancer or a lymphoma, it is possible that we may refer to a center that has expertise in those conditions rather than doing that ourselves, mainly because sometimes there is a need to actually see a hematologist for more workup, or an MD geneticist, especially if we're thinking about a syndrome or something syndromic, or anything that's impacting a child. As I mentioned, we can also identify outside external resources that might benefit someone, because this is one of those things where, as we're seeing in the questions, there's a lot more to it than maybe we presented. This is really the bare basics, but there are a lot of other different types of blood cancers and things we didn't touch on. And so if anyone's looking for more resources, we can certainly try to pass those along if we're working with you. All right, next slide. Okay, so the Impact program is a free and voluntary program through Thermo Fisher. Like I said, it's a benefit. To be eligible for the program, you need to be on a Thermo Fisher medical plan. So that would include employees and dependents, so spouses, domestic partners, children, any of the Thermo Fisher plans. So it could be United Healthcare, it could be UPMC, Kaiser. You don't have to have a current cancer diagnosis. It could be a past diagnosis or even just a family history without a diagnosis. So any of those would apply. Okay, next slide. Enrolling in the program is rather simple. All you would need to do is email us at impact@thermofisher.com. This is a mailbox that just comes to the three of us. What you would need is just to provide your name and an email address. You do not need to provide any additional information. From there, what we do is send an electronic enrollment form. That's our consent form, where you can read a little bit more about our privacy policies and things like that. And that will be a form that you can submit online. And then when we receive that, we'll follow up with an email introducing you to your navigator and then providing the next steps for scheduling that first introduction call to get started. Okay, next slide. And then lastly, as was already mentioned, and I think provided in the chat, we do have a page on the Colleague Service Center for Impact. You can go there and just type it into the search bar. If that doesn't work and you're not able to find it, please contact us and we'll try to help direct from there. I think in the past, we've had a little bit of difficulty sometimes with CRG employees not being able to access it. And so if that's the case, please reach out and we will get you the information that you need. There is also information on My Benefits. And so again, you can just search for it and find that information there, or just email impact@thermofisher.com and we can provide it for you. Okay, next slide. And then lastly, if you would like to reach out to any of us individually, these are our email addresses. Like I said, the shared one comes to all of us, but if you want to reach out to any of us specifically, you can feel free to do that. And with that, I think in the last 15 minutes, I'm going to turn it over to Jillian Sotelo to moderate the questions and answer as many as we can during this time. And then, like I said, if we're not able to answer all of them, we can certainly try to follow up with an email afterwards. So Jillian, go ahead. You can ask either about the cancers or the talk that Julie gave, or even about the Impact program. We're happy to address those now.
Thank you guys both so much. I feel like even just putting this together and hearing Julie, you go through the information again, I learned a lot still. I do just want to remind everyone that this session was recorded and it will be posted on our colleague service center. That does take a little bit for them to post that. So likely mid-week next week or the end of week next week. So if you go to the link that was provided in the chat, you will be able to find that at some point next week, the recording of this presentation. So on to some of the questions. Kelly, there's been a few questions that have come up about genetic testing and insurance. Do you want to talk about what that looks like both within the program and outside of the program?
Yeah, so in general, it really does depend. So unfortunately, I can't give a very clean answer to that, except that most insurance companies, including the ones provided by Thermo Fisher, will require certain criteria to be met for it to be covered by insurance, the genetic testing. That's certainly something we can discuss through the program. I will say the impact program, when we facilitate genetic testing, we probably have a little bit looser guidelines than the insurance, but for the most part, if there is a concern in the family history and you meet those guidelines, it typically is covered. It can be a little bit more difficult, I will be honest, with the blood cancers and lymphoma, mainly because it's a newer, the genetic testing for it in the grand scheme of genetic testing for cancer is quite new. It hasn't been around as long as, say, breast cancer, prostate cancer, colon cancer, some of our more common types of cancers that we've been testing for quite some time. Certainly when it comes to things like determining best matches for bone marrow transplant, and considering treatment effects and things like that, or even if there's a syndrome, that's one of the reasons why sometimes if someone comes into the impact program, we may identify and may kick that over to a genetics clinic or an MD geneticist or hematologist, because it does get a little bit more complex and they would have the tools to work with the insurance company on medical necessity and things like that. So I'm sorry I can't give you a very clear answer when it comes to that question. It really just depends on the personal and family history.
Thank you. And Kelly, another question just about enrolling in the program. If we have an employee who has a relative who is not part of Thermo Fisher or is not on the medical plan, are they still eligible to enroll?
So an employee that's not on a medical plan, unfortunately, they can't go through the typical enrollment process and be eligible for all of the services that the impact program provides. However, if someone is in that situation, if they reach out to us, I will sometimes offer to have a one-on-one call, just colleague to colleague, and discuss the situation and see if there are any external resources that we have that I could provide to help. I would say, we do this quite often, and we can work that out on an individual basis. But like I said, there wouldn't be the eligibility for some of the services like the second opinion or the genetic testing or things like that, but we can certainly talk and see if there are other resources that we have available. I also, to follow up on that, because I saw this question as well, about if there's a relative with cancer that that doesn't qualify for the program, but the employee does. What we would recommend is the person who is eligible for the impact programs, the employee, would enroll and we could discuss the relative's diagnosis. Again, there would be some limited services there, but we could certainly provide that additional support and maybe discuss referrals and provide resources in that situation.
Okay, thank you. Now, Julie, a quick question for you. The question came up, does radiation treatment for other types of cancer also increase the risks of leukemia and lymphoma?
That's a great question. One of the classic examples of that are younger people who have had lymphoma as a young person and get chest radiation. That can increase the risk for breast cancer. The other way around, I am not aware of that increasing the risk for blood cancers.
Great. There were a lot of questions in here about multiple myeloma. There's actually a great string in the Q&A if you're interested in looking at it. And I just want to mention that multiple myeloma is having quite the year this year. And as Kelly mentioned, we are genetic counselors, we're not physicians. But I am aware that there are multiple new treatments for multiple myeloma that have been approved by the FDA in the spring and summer of this year. And those include combination therapies and also include immunotherapies primarily. So I would just recommend that you meet with a specialty center regarding multiple myeloma. There's quite a few of those. There's also a very robust multiple myeloma foundation, International Myeloma Foundation, excuse me. And they have a really amazing article that they produce every year. I will link to it. Actually, they call it the State of Myeloma in whatever year. And I'm going to link to it in the chat because I know that that has been a question that's come up from multiple people. And they're a great place just to get their newsletter and get additional information. There's also been some other questions about LGL leukemias. It is fairly rare. And I would say working with a specialty center is probably your best bet there. There's a few of those in the country. Certainly, if you have other questions about what those may be, you can go ahead and email Impact and think about enrolling, and we can work on helping you find some more resources. One question that came up that I thought was interesting, and Julie, I know maybe we can tag team this a little bit. There was a question of how do you distinguish between the different types of leukemias? And my understanding is that when they're looking at the somatic genetics of these types of leukemias, that's one of the best ways to have an indicator of what kind of leukemia you're dealing with. Julie, how do you feel about that? What's been your experience?
So there are different ways to tell. First of all, just symptoms can play a role in distinguishing the type of leukemia that somebody might have. Just in general, a more rapid onset of symptoms that progress quickly would be more of an indicator of an acute form of leukemia. Then as far as whether it's the myeloid or the lymphoid type, it's really something that can be seen by looking at the blood cells to be able to get a sense of which cells are affected.
And this particular individual asked about CLL, so chronic lymphocytic leukemia, and LPL, which is a type of lymphoma. And as you had mentioned, there's actually specific proteins they're looking at and specific genes within the blood that indicates one or the other. And of course, that is something that would be done by a physician or a specialty site.
Correct. And there are actually, special pathologists. So as you all know, a pathologist is a person who looks at tissue and helps establish the diagnosis of a cancer. Diagnosing blood cancer, just like some other cancers, can get pretty complicated. And there are specialized pathologists called hematopathologists that specifically work to help differentiate between the different types of blood cancers.
So there's another great question that came in. It says, it was stated that immunodeficiency is a result of these cancers. Is it possible that the immunodeficiency comes first and leads to the cancer itself?
So when we talk about the immunodeficiencies in relation to the cancers, we were talking about it more in the sense of one of the signs that we can see in conjunction with lymphomas. So in some of the inherited syndromes, we can see somebody who has immunodeficiency that goes along with increased risk for lymphoma. I'm not sure if I answered that question. I don't know if Jillian or Kelly, you have anything to add to that.
Yeah, I mean, I would say that is definitely a possibility. Immunodeficiency can come first and lead to an increased risk in certain types of cancer. I think what Julie was saying, when we see immunodeficiency and the lymphoma, it's more syndromic in nature, where we're seeing immunodeficiency for reasons that are not necessarily the same as why we're seeing the lymphoma, but it's the syndrome that's causing both. It's a bit complex, and that's a really great question, but certainly immunodeficiency can lead to cancers also. Um, so I don't know, Jillian, do you want to
No,
go
I
further
think
into this?
that's
We're getting more into the weeds, but it's such a good question.
yeah, I think it's a chicken and the egg to a certain extent, right? And I think one of the things we haven't really talked about is that so often these lymphomas and leukemias, because they have sort of generalized symptoms, can be missed for a while, particularly in young, otherwise healthy individuals, right? And so I think it's really hard to know what the natural history is for some of these cancers. But yeah, I think it is a good question. I think you guys have sort of answered it as far as we know. And again, just to underscore, we're not physicians that treat lymphomas or leukemias. We're genetic counselors that help people that have had diagnoses or at higher risk for these diagnoses due to their genetics. So, that I think that's a good question overall, but probably that's the best answer we have at this point. One question that came up, Kelly, is, this individual wanted to know about genetic testing for a genetic mutation that was found in a family member that isn't a cancer diagnosis. Can you talk a little bit more about what kind of genetic testing we do within the group?
Yes. So this is a really good question, and one that comes up quite a bit. So while we are genetic counselors and we have been trained in all different types of genetic disorders and different types of genetic testing, I will say within Thermo Fisher and our current expertise, what we've been doing the most has been cancer genetics. And so if it's a non-cancer related gene mutation, if we don't typically test for anything outside of cancer. However, without knowing the details, it's hard for me to say. I think this is a situation where if you can either enroll or just send us a quick email and maybe let us know what the gene is and the syndrome. And what we can do is maybe provide information about a genetic counselor in your area or a genetic clinic that that you would be able to make an appointment with, or we can talk a little bit about, depending on what the condition is, we may be able to give you a little bit more information. It's just hard to know without knowing what it is. So I would encourage you to reach out to us, and we can maybe decide whether or not it would be applicable or appropriate for you to enroll in the Impact program. And if not, we can maybe get you to the right place.
Yeah. Okay, that's great. And I just want to also just mention too, as part of that, is a few people have come up saying that they're caregivers, right? If you are a Thermo Fisher employee and you're on the medical plan and you are caregiving for somebody who has one of these cancer diagnoses or another cancer diagnosis, you can enroll in our program and receive caregiving support like resources. You don't have to have the cancer yourself. So I do think I just want to point that out. That is something that we provide as part of our service. And that's even if the person who has cancer, you're caregiving to them, maybe it's a relative like an elderly parent and they're not a Thermo Fisher on a Thermo Fisher plan or a Thermo Fisher employee. That's okay. We can still provide you resources with you enrolling in our program, right, Kelly?
100%, absolutely.
I am just looking through the Q&A. Give me a second. There's quite a bit here. I just want to make sure that there isn't anything that we missed. I hope that we have answered as many questions as we can. I really appreciate everyone coming to the talk today and for hearing more about us. As a reminder, this was a recorded session. It will be available on the colleague service site. The link is at the very top of the chat. It will be available sometime midweek to late week next week. So just keep an eye out for that. Additionally, if you feel like you would like to enroll in our program, you can email us for an enrollment form at impact@thermofisher.com. We've also put that email in the chat. Thank you everyone for coming, and especially thank you to Julie and Kelly for presenting today. And everyone have a good rest of the afternoon.